Begin, madam, please. Go ahead.
नमस्कार डॉक्टर्स, मैं डॉक्टर संगीता श्रीवास्तव, प्रेसिडेंट आई एम नवी मुंबई डॉक्टर्स फाउंडेशन के 143rd वेबिनार में आप सभी का हार्दिक अभिनंदन करती हूँ. आई ऑल्सो वेलकम टुडेज एमिनेंट स्पीकर डॉक्टर महेश घोगरे, कंसल्टेंट इंटरवेंशनल कार्डियोलॉजिस्ट फॉर टुडेज वेबिनार. नवी मुंबई डॉक्टर्स फाउंडेशन की हमेशा यह कोशिश रही है कि विभिन्न क्षेत्रों के सीनियर डॉक्टर्स के साथ मिलकर डिफरेंट टॉपिक्स पे समय समय पर सीएमई ऑर्गेनाइज करें, ताकि मेडिकल फील्ड में लेटेस्ट क्या चल रहा है उसकी अधिक से अधिक जानकारी आप सभी तक हम पहुंचा सकें. बिफोर मूविंग टू द साइंटिफिक सेशन, आई रिक्वेस्ट ऑल द अटेंडिंग डॉक्टर्स to please keep your mobile on mute mode, video off, and please put your questions in chat box. Now, moving on to the scientific session, I would like to introduce our speaker, Dr. Mahesh Ghogare. Dr. Mahesh is consultant interventional cardiologist at Terna Specialty Hospital and Research Center, Navi Mumbai, with more than 10 years of wide work experiences and performed more than 10,000 angiographies and more than 3,000 angioplasties. He did MBBS, MD medicine, and DM cardiology. Dr. Mahesh is managing director of Ghogare's My Heart Clinics, his own clinic at Nerul. Dr. Mahesh is international associate at American College of Cardiology. Numerous prestigious awards, papers, and publications nationally and internationally to his credit, name a few. He has been listed in Mumbai Top Doctors 2018 by Internovation INC in its 6th annual listing for his remarkable work in cardiology. Medical Excellence Award for prestigious Indian Solidarity Council. Now, I invite Dr. Mahesh for his talk on basics of angiography. Over to you, Dr. Mahesh.
Thank you, respected Madam Srivastav, all dignitaries and Navi Mumbai Doctors Foundation for giving me opportunity for today's topic. So I will first share my screen. Is it visible, madam?
Yes, visible, clearly visible.
Yeah, I am audible, no?
Yes.
So we will start. Today I am going to talk in brief about coronary angiography. What are the precautions? What are the indications? What are the contraindications? And what are the post-procedure requirements? What we have to see once patient has done with angiogram. This is very basic thing, and each and every one of you have been referring patients for angiography, and these patients come back to you. Come back to you after angiogram. So we should know the basic things about angiography. So what is angiography? Angiography is also called as angiogram or arteriography. So basically it is visualization of lumen of the vasculature. Any vessel from head to toe can be visualized by the angiography. So if it is for brain, we call it as cerebral angiography. If it is for heart, we call it as coronary angiography. And if it is for any of other vessels other than these two, we call it as peripheral angiography. So most commonly used method for visualization of vasculature is direct angiography, that is conventional angiography or catheter angiography. There are other modalities of angiographies also which are considered as a non-invasive, but still they require vascular assays, that is venous assays, as well as amount of dye, which is more as compared to the conventional angiography. For example, for brain, we do digital subtraction angiography or MR angiography, that is MRI angiography. For heart, we can do CT coronary angiography, that is CTCA. So all these modalities require dye to be infused in the body for the visualization of the vessels. So before proceeding to the coronary angiography, I will like to comment on what is typical angina and what is a typical chest pain. This is very, very important. So typical angina means patient gets either retrosternal or left side of chest pain, which is constricting in nature, or sometimes it is just uneasiness. But that should be tightness in the chest. Most probably it is associated with back pain or left shoulder pain. It is not mandatory that there should be this association or this radiation has to be there. But typically cardiac pain lasts for more than 5 minutes. If chest pain is less than 5 minutes, it is less likely that this is related to heart. So this is typical angina, and any pain between lower jaw to the umbilicus can be related to heart. I got one patient whose the only complaint was he gets jaw pain after walking a certain distance, and once he stops, that jaw pain used to be relieved. He was seen by a dentist, and after that he came to me, and we had done the angiogram, and it was suggest of critical proximal left anterior descending artery block. So any pain for that matter, if it is typical angina, it has to be related to heart. And if we ask to the patient where this pain is exactly, if he points it at one point, suppose right side of the chest, center of the chest, or left side of the chest, if it points by a finger, so 99% you should be sure that this is not related to heart. So typical angina and atypical chest pain, this is important. So all patients with acute coronary syndrome encompasses unstable angina, means patient have typical angina, but his ECG, 2D echo, and cardiac markers are negative. If patient has got non-stimulation myocardial infarction, he has got ECG changes, positive cardiac enzymes, echo may be normal, but this has got typical angina, and STEMI has got clear-cut stimulation myocardial infarction. All these AC spectrums, they should go for angiography as early as possible. Those patients who are ultra stable, we can wait for a couple of hours or a couple of days, but ultimately they will land up with angiogram some or other day. You should be knowing the most common symptom which may lead to angiography is dyspnea. Dyspnea is very important. Just suppose patient was walking say 5 kilometers a day previously for 4 to 5 years, and now he is not able to walk say even 2 kilometers. So we should ask proactively what happens exactly. So he will tell, doctor, I was walking previously for say 5 kilometers, but now the distance is gradually reducing. I am getting tired, or I am getting a bit breathless while walking or climbing stairs. So typically climbing 2 floors of building, it takes almost 8 METs requirement. So METs is basically a unit that will determine oxygen supply to the heart. So 2 floors climbing requires 8 METs. If patient is not able to climb 2 stairs without discomfort, then he has some problem with blood circulation. Either there is increased demand in the uh, 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 cardiac supply, or there is less supply from for the heart vessels. So this is dyspnea. So any patient with NYH class 2 or 3 dyspnea should be posted for angiography. Typically, the most common symptom in diabetic patients, elderly patients, or any comorbid patients, typical symptoms is dyspnea or breathlessness. So we should keep in mind all these things. Third and most common symptom is patient get just bit of tiredness and excessive sweating after walking couple of flights or short distance. So if patient has got intermittent bradycardia because of arterial involvement, like particularly right coronary artery, which gives supply to the SA node and AV node, these patients may get recurrent bradycardia, and these patients may experience intermittent pre-syncope or syncope. Such patients should be evaluated by ECG, 2D echo, treadmill, and after that, we should consider angiogram in these patients. Angiography is also commonly done in all patients who are posted for major surgery, whether it is cardiac surgery or non-cardiac surgery. In cardiac surgery, we are going for thoracotomy. So it is class 1 indication that if patient is going to be going for aortic wall replacement or say mitral wall replacement or closure, these patients should go for angiography. At the same time, if by any chance there is coronary involvement, we can get bypass surgery at the same time. And all non-cardiac major surgeries like bilateral TKR, or any orthopedic surgery, or any major abdominal surgery, or any major thoracoscopic surgery, these patients should be evaluated by angiography before proceeding to the major surgery to rule out coronary artery disease. Because once this major surgery is done, it is very difficult to give dual antiplatelet drugs if these patients need angioplasty or bypass surgery in emergency. So, and most important nowadays, family history. If any of first degree relatives of patients come to you for opinion, say one patient has got his father heart attack below 55 years, or in male below 55 years and in females below 65 years, which is considered as a premature coronary artery disease. In such patients, there should be very high degree of suspicion for coronary artery disease, and even we can lower the limit for angiography, and these patients should be treated as a different subset. Those patients who have strong family history of coronary artery disease or sudden cardiac deaths. In such patients, we can get CT coronary angiography at least to rule out coronary artery disease in early stage of the life. I got one patient. He was young, just married, young couple. His age was just 32. And wife was 29 years. They were staying at Ireland. They are Indians. They come to me just for evaluation, that his father died of heart attack at the age of 40. And on routine examination, we just found some xanthelisma around the eyes. And we have run the battery of tests, and there was hypercholesterolemia, dyslipidemia. SCRP, that is C-reactive protein, was very high sensitivity C-reactive protein. And he was routine table tennis player, and he had some difficulty. He has to stop in between. He has excessive breathlessness. I advised him angiogram. Luckily, he agreed for that, and it turned out to be critical triple vessel disease. And he underwent bypass surgery at the age of 32. This is last year's story. So, in those patients who have got very strong family history, the suspicion has to be very high, and they should get angiogram earliest. So, if we advise the angiogram, we should look into the certain factors which in which patient we should not advise angiography immediately. For information that there is no absolute contraindication for the angiography. Each and every patient, if required, if it is life-saving, has to be posted for angiography. But if patient has suppose infection, evidence of infection, like patient is running fever, we don't know the cause of fever, whether it is upper respiratory tract infection, lower respiratory tract infection, or urinary tract infection. If it is not urgent, we have to wait, because any fever can complicate the matter if these patients require angioplasty. Because once we put a stent, we can't stop dual antiplatelets at any cost, at least for initial 3 months. So any fever or any sort of infection may lead to low hemoglobin or low platelet count, and that may worsen the things. So any fever, we should wait at least for a couple of days to fever to subside if it is not urgency. Any active bleeding, generally gastrointestinal bleeding in the form of bleeding piles. This is most common form. So in such cases, we should first treat that cause, and after that, we should proceed for the angiography. Very common question, females of childbearing age, if they have got active menses, this is a relative contradiction. Even if these patients are having active menses, we can proceed with the angiogram. This is not absolute contradiction. This is just relative contradiction, except those patients who have got very heavy bleeding during menses. Any renal impairment in the form of rise in creatinine, or past history of CKD, or past history of dialysis for any cause, should be routinely evaluated with the serum creatinine, blood urea nitrogen, and after that only we should consider angiography in these patients after correction of food status, as well as giving certain agents. Any acute patients with decompensated heart failure or patients with acute pulmonary edema, we should wait. First, we should stabilize these patients by say CPAP or endotracheal intubation. We should optimize their fluid status. We should give them enough diuretics to get rid of edema of pulmonary congestion, abdominal congestion, and edema of it. And once they are stabilized, we should go for angiography in such patients. Don't be in hurry. This is very routine practice at many places. That's a patient is in acute pulmonary edema, and they just took this patient to the cardiac catheterization lab, and they proceed with angiography and if required angioplasty. And majority of these patients, believe me, they don't survive. So any patient with acute decompensated heart failure, class 4 dyspnea, they should be first stabilized. We have to wait. We should give them a window of natural management, and after that only we should consider angiography in these patients. And any known patient with severe allergy, suppose patient gives history of severe urticaria after eating something like prawns, or after exposure to the cold or certain flowers or dust, they should be taken very seriously, because contrast can cause severe life-threatening allergies, and we are blamed for that. So contrast allergy is one of the relative contradictions. It is manageable thing, but we should inquire about these things prior to angiography. So what are the investigations? This is routine battery of tests. Each and everything mentioned here has got some importance. For that matter, complete blood count. We have to see the hemoglobin count and platelet count, and to rule out infection, WBC count. Serum sodium potassium. This is very important. In India, this is very common thing that once any surgery is done, the relatives come to us with lot of fruits, juices, coconut water, and coconut water, bananas, juices, they are very high rich in potassium content, and this may cause hyperkalemia. So hypo and hyperkalemia are very dangerous for with relation to heart rhythm. These hyperkalemia lead to complete heart block as well as ventricular tachycardia and ventricular fibrillation. So any cardiac patients, we should ask them not to take coconut water or excessive fruit juices unless we know their potassium status. If patients potassium is higher, we should strictly advise them to avoid these things. Creatinine level, this is very important, because serum creatinine is the marker which we monitor after angiography or angioplasty for contrast-induced nephropathy. This is very common. Generally, elderly patients, diabetic, female with multiple comorbidities, with uncontrolled hypertension, these are subsets for contrast-induced nephropathy. Any patient who have creatinine on higher side, they should be well hydrated. Before going for angiography, they should be put on IV fluids, and even after angiography, they should be on IV fluids for a couple of hours, depending on the creatinine level. X-ray chest, this is not commonly done, but this is must, because to rule out lower respiratory tract infection if there is patch. Secondly, to see the vasculature, that is aneurysm of aorta. Once I had a call from corporate hospital, patient was referred by CVT surgeon. This was routine pre-operative angiography, and I have not seen that patient. That patient was directly on table. I started with angiogram. Right radial was not palpable. Taken femoral and done the fluoro. There was massive aneurysm. The aorta was so tortuous, and it was very difficult to manage catheters in such aortas. And if by any chance that aortic aneurysm ruptures, this is mishap. Patient is not going to come back again, and this is not manageable. So X-ray chest, in my opinion, is must, but this is not commonly done. Triple H is obviously to rule out infection. ECG and 2D echo to gather the information whether patient has ACS or what previous ECG changes or sequelae of old myocardial infarction, and 2D echo just to get the idea of regarding left ventricular ejection fraction. Lower the ejection fraction, more careful we have to be, because if ejection fraction is less than 30%, there are very high chances that these patients may have mitral regurgitation because of LV dilatation. And even if you put a 10 ml of dye for angiography, these patients are going to land up with acute heart failure surely. So we have to be very careful with respect to ejection fraction. And these patients, even if creatinine is on higher side, should not be given IV fluids unless it is monitored by cardiologist. So once we are done with the investigations, what are the pre-operative instructions for angiography? Patients come to you and say, doctor, whether I should eat or not, how many hours I should be fasting. So typically it should be 4 to 6 hours fasting before going to the angiogram. Patient can take all medications, better to avoid anti-diabetics, because majority of hospitals, they have number of procedures lined up. Suppose there are 4 angiographies lined up today morning and first patient is converted into angioplasty. It may take another 3 to 4 hours and patient is fasting. Generally, this is neglected at many places, that we don't monitor sugars every 4 hours, which is should be the ideal norm. So these patients may land up with hypoglycemia, and hypoglycemia is very dangerous in heart patients. Adequate hydration, as mentioned, to prevent contrast-induced nephropathy is also important. Many times it happens that patient is, we ask them for fasting since morning 6 o'clock, but patient doesn't take anything after say night after 8 o'clock, 9 o'clock, whatever they last meal after they didn't take, and these patients land up with hypovolemia, and this may worsen contrast-induced nephropathy as well as hemodynamic instability during angiography. So adequate hydration is very important pre-operatively. So once we are done with the angiogram and patient is discharged, suppose patient is having non-obstructive coronary artery disease or insignificant disease in the angiography, what we should observe after discharge, or patient, if patient is sent to the home, we should typically ask patient to monitor right radial side or right femoral side from where angiography is done. We have to look for the hematoma. There have been incidences in elderly patients that they just take out that sticking, dynaplast sticking, and they have got huge right forearm arm edema and hematoma, and they are landed up with fasciotomy. So it is very important. They should frequently examine the limb, whether it is upper or lower limb, for hematoma. Secondly, we should try to feel the pulses. We should look for the movements of fingers or right lower limb toes, whether this movement is there or not. We should ask these patients to monitor urine output, means just whether they have passed urine or not after angiography, because this is to prevent nephropathy. Patients can get fever after discharge. This could be related to contrast allergy as well as infection, because many of the labs they use material. So we should monitor this. We should look for the contrast allergy. Any sort of itching or urticaria symptoms after angiography, we should be noticed early as possible, because sometimes this may lead to severe allergic reactions, and patient may have respiratory difficulty. So we should monitor for neurological signs and symptoms. It is very common that during manipulation of catheters, some of the atherosclerotic plaques, they just dislodge and they land up with the some cerebral vessels, and patient gets the stroke. This could be TIA. This could be this can turn into massive infarct. So all 4 limb movements, change in voice or facial weakness, we have to monitor. So these are common instructions after angiography. Now this was all about indications and pre and post angiography management on your part. So coming to cardiologist perspective, performing good coronary angiogram and its right interpretation forms the basis of good coronary intervention. This is very important. More number you are going for angioplasty, more information you need in the form of angiography. And this is very difficult task. Not all angiographies which come to us for second opinion or done at the periphery, they don't give right information in the right amount. There are multiple techniques. The shoots while angiography should be enough lengthy to gather the information, to look for the collaterals, to look for the complete filling of the vasculature. This is lacking at, with many cardiologists. This is an art which is often taken for granted and not uncommonly lacking in a good number of international cardiologists. I have seen many angiograms, they were reported to have critical blockages or they were reported to have very small blockages. And once we have seen the CD very rightly or very carefully, or once we repeat the angiogram again, the things have turned vice and versa. Angiographically, it was reported say 90% left main coronary artery block. It found to be just a minor plaque, or there was no plaque at all, and vice versa. So it is very important to perform good quality angiogram at good machine by a good doctor. So obviously, this is not without complications. Mortality is very rare. Incidentally, this could be related to catheter manipulation and a dissection of the aorta or dissection of the left main coronary artery while doing angiography, or ventricular tachycardia or ventricular fibrillation, or sudden hemodynamic compromise, or cardiac arrest. This is very, very uncommon. Most common complication is related to local site complication. Immediate complication at local site are hematoma, and late complication is formation of aneurysm. In those patients who are hypertensive and their hypertension is not controlled, in these patients there is risk of late aneurysm formation. So particularly hypertensive patients, their blood pressure has to be controlled after angiography or angioplasty, and after we should look for puncture site even for a couple of months. We have to advise them just look at the puncture site, that radial or femoral, and report us if there is any swelling, pulsatile swelling. So coming to the assay side, nowadays most commonly angiogram is performed to the right radial artery. If it is not palpable or if it is tortuous, we can go through the right ulnar artery as well. But for that matter, we have to go for Allen's test. We have seen the patency of the palmar arch by occluding the radial as well as ulnar artery alternatively. And if palmar arch is patent, then only we should attempt for ulnar artery. This is very important. I have seen one patient done the angiography at periphery by radial. That was not accessible, and they have turned to ulnar SS, and that patient landed up with right hand gangrene. So ulnar, radial, these are preferable, but for that we should go for the palmar arch patency test. Second most common site is right femoral or right groin. This is since the introduction of angiography, the last 30 years, this is most common site. Radial artery arterial assist is nowadays preferred, and we've got thinner sheets which can accommodate 7 French catheters for interventions. So right radial is most commonly performed nowadays, and this has got less complications as compared to right femoral. Alternatively, we can use left femoral, left radial, left ulnar. If there are difficulties with any of these, we can go to the antecubital also. Antecubital vessels can be used for angiography. These are different catheters. This Tiger catheter is used for radial access angiography, and for femoral, most commonly used is Judkins left and Judkins right. These are different catheters depending on the size of the aorta, location of the ostia of the coronaries. We have to use different catheters. So this is typical angiography picture that we go through the femoral route. This is catheter, and this sits in through the coronary ostia, and we inject dye through this catheter, and this opacifies the coronary circulation. So contrast agent, this is important. Nowadays, majority of cath labs use non-ionic contrast. Previously, they were using ionic contrast, and with non-ionic contrast, the allergic reactions are almost gone. Small urticarial reactions are still common with non-ionic contrast. And importantly, those patients with renal compromise should use Visipack. There are different types of type. Omnipack, it has got high osmolality. There are two types of Omnipack. One comes with 350 and one comes with 370 osmolal dye. Visipack is of lower osmolality. So Visipack is more safer in renally compromised patients. So now coming briefly to the coronary circulation. right coronary artery and left coronary artery. Basically, coronary arteries arise from the coronary sinuses. There are three coronary sinus: right coronary sinus, left coronary sinus, and non-coronary sinus. So, right coronary artery arises from right coronary sinus. Left main artery arises from left coronary sinus. There are multiple anomalous origins of coronary arteries. So, right coronary artery predominantly supply, as name indicates, to the right side of the heart. That is right atrium, right ventricle, posterior part of interventricular septum, and some part of left ventricle. It depends on the size of the right coronary artery. There are terminology like dominant circulation. Dominant circulation means which artery supplies more to the heart. Suppose if we say there is left dominant circulation, so left circumflex artery is bigger as compared to right coronary artery. If we say right dominant circulation, right coronary artery supplies majority portions of the heart. So 85% of the normal persons have got right dominant circulation. So right coronary artery supplies majority of right part of the heart. Importantly, it also supplies SA node as well as AV node. So many patients with inferior wall MI related to right coronary occlusion, they present with giddiness or presyncope or complete heart block because of the involvement of SA node or AV nodal branch. And typical symptom in this patient is syncope, giddiness, and fall, as well as low heart rate. Left coronary artery, it normally arises from left ostium, and it supplies left side of the heart, as name indicates. That is left atrium, left ventricular, anterior part of the septum, and part of bundle of his. So majority of conduction system of the heart is supplied by right coronary artery, and some part is supplied by left coronary artery. This is typical normal coronary angiography. Right coronary artery, it has got three parts: proximal, mid, and distal right coronary artery. Then distal RCA gives right to PDA and PLV branches, that is posterior descending artery and posterior lateral arteries. Left side, we have got left main artery, which divides into left anterior descending artery and left circumflex artery. This left anterior descending artery has got diagonal branches and septal branches, while left circumflex has got OM branches, that is obtuse marginal branches. So normally we call left anterior descending artery as widow's artery, because previously there was no treatment, and once there is acute occlusion of LAD, that is left anterior descending artery, the patient most probably lands with ventricular tachycardia, fibrillation, and very high chances of sudden cardiac death unless these patients lead to DC shock. Nowadays, this is most common cause of death in heart attack patients. Out of hospital mortality is because of ventricular tachycardia and ventricular fibrillation. So there is campaign running all over the Mumbai that many of the prominent society, gyms, bus stations, police stations, they have this DC shock machines implanted. So coming to the brief management, this is right coronary artery and this is right coronary angiograph. There is a critical block in the mid portion, as well as there is critical block in the distal portion. Same is for the left coronary artery. There is critical block in this left anterior descending artery just before the origin of diagonal. These are called as focal lesions. Focal lesions means less than 2 centimeter lesions, and rest of the artery is clean. So in such cases, angioplasty is must, because these patients are very prone for acute myocardial infarction, and this could be the presentation once the thrombus has got after myocardial infarction. Now this angiographic picture shows left main disease, and this is a cardiac emergency for bypass surgery. In first picture we can see ostium of the left main coronary artery is diseased. This is very much narrowed, and in second picture we can see distal left main coronary artery is narrowed. This left main subset is like a time bomb, and these patients should be intervened early as possible. Ideally, these are candidates for emergent or urgent bypass surgery. But nowadays, we can treat such patients with angioplasty as well. but with the support of IABP, the cost is bit on higher side as compared to bypass surgery. So now we have seen the focal lesions, we can be managed with angioplasty. Left main disease, first choice should be bypass surgery. And if patient is not ready, or if it is urgency or emergency, we can go for emergency angioplasty. Now this is typical picture of diffuse triple vessel disease. Means this patient has got diffuse disease in left anterior descending artery at multiple locations, multiple narrowings in the left circumflex. There is some narrowing in the left main artery. The right coronary artery is also diffusely diseased. Diffuse means throughout the length, these vessels are diseased. Such patients are not good candidates for angioplasty as well as bypass surgery. If these patients are not very much symptomatic, these patients do best with medical management. So medical management is also one of the important modalities of treatment. Not only angioplasty and bypass surgery suffices in these patients. And as long as patient is asymptomatic, and if we keep these patients on natural history, these patients far better as compared to angioplasty or bypass surgery, because for bypass surgery, there is no place to put grafts, and for angioplasty, there is no place to put stent at good landing zone site. And if we put stents at disease segment, there are very high chances that these patients will come back with instant restenosis or acute coronary occlusion after stenting. So diffuse triple vessel disease patients are best managed with medical management. So this was extreme scenarios. What if there is borderline disease? So this is right coronary artery, there is 50% block. We typically say moderate coronary disease when there is 40 to 70% blockages. So such patients, there is dilemma whether we should put a stent or not. So we have got one modality of treatment, that is FFR. We call it as fractional flow reserve. As name indicates, it estimates the flow reserve in the typical coronary artery. So we have to put a catheter, coronary wire, distal to the lesion, and just it calculates the ratio, what is the pressure distally and what is the pressure proximal to that supposedly block. If this ratio is less than 0.8, it means this lesion is significant. After giving hyperemia, means adenosine, in such patients, suppose patient has got 50 or 60% block, we should ask cardiologist for FFR, and we have to give adenosine so that this lesion will dilate and the flow will increase. In spite of increasing flow, if there is significant drop in pressure, then this FFR will come positive. It indicates that this lesion is physiologically significant. Even if anatomically it doesn't significant disease, physiologically it is obstructing the forward flow, and this patient should be posted for angioplasty. There are different modalities. So if suppose patient is having severe COPD or severe bronchial asthma, and this patient cannot be given adenosine for FFR, then there is RFR. So it means we can calculate the same value without giving adenosine by different catheter. And FFR, IFR, and RFR, these are three different things. The only difference is FFR calculates this value over full length, IFR calculates this length over diastolic period, and RFR calculates this value at lowest sub-cycle level, means full cycle, diastolic cycle, and lowest cycle. These are just modifications of FFR. So less than 0.8 FFR is considered significant. There are challenges with multiple lesions in single coronary artery, or if there is disease in left main coronary artery, for even for FFR. And I won't go into details, but still we can get accurate measurements with FFR in such lesions as well. Now coming to the last topic, this is very common question in day-to-day practice, that patients come to us and ask, doctor, we are advised angiography, whether we should go for CT coronary angiography. So answer is yes as well as no. There are different things. The machine has to be very good. The reporting person has to be very familiar with coronary physiology. The only difference between CT brain and CT coronary angiography, that heart is moving structure, so it doesn't accurately pick up the blockages in the coronary vessels by CT coronary angiography. There are multiple motion artifacts, and machine has to be above 64 slice for CT coronary angiography to be effective. Uh, if young patients come to you with atypical chest pain, means he says that this pain is pricking type intermittently at one point, ECG is normal, 2D is normal, TMT is negative. In such patients, we can ask this patient for CT coronary angiography just to rule out coronary arteries, not rule in. If there is, suppose CT says that there is 20% lesion, we should again go for conventional angiography. So if CT coronary angiography is absolutely normal, then we can take it as a positive report, and these patients can be safely put on medical management. But if by any chance there is even smallest possible lesion, we should post this patient for conventional or catheter coronary angiography. CT coronary angiography has got value in post bypass surgery patients, because multiple grafts are put at multiple levels. With conventional catheter angiography, it is difficult to localize the origin of these grafts. In those patients with dilated aortic root or aortic aneurysm, CT coronary angiography has some role, but it is not recommended for routine use. So this is typical CT coronary angiography, normal CT coronary angiography report. If it is normal, then it's fine, because there are two things. One is CT coronary angiography, and another is CT calcium scoring. CT calcium scoring means they just do the cine and determine the level of calcification in the heart vessels. This doesn't indicate your intraluminal coronary blockages. So if this CT calcium score is more than 400, then we have to go for CT coronary we have to go for conventional coronary angiography only. But if this score is less than 400, we can go for CT coronary angiography. So CT calcium scoring is done first, and after that, if required, we have to go for CT coronary angiography. But by and large, CT coronary angiography is not recommended as modality to rule in the coronary artery disease. That's it for today's session, and thank you.
एक्सेलेंट प्रेजेंटेशन डॉक्टर महेश. मेरे दिमाग में बहुत सारे क्वेश्चंस घूम रहे थे, पर आई थिंक 99% क्वेश्चंस का आंसर आपने बहुत ही खूबसूरती से दिया है. सो एक छोटी सी बात है, जैसे कि कोई भी पेशेंट है, उसको कोई प्रॉब्लम नहीं थी, वो रूटीन उसका जो एनुअल चेकअप होता है उस पे वो गया, उसकी ईसीजी में छोटे छोटे चेंजेस हैं, तो क्या हम टीएमटी, स्ट्रेस टेस्ट, 2D को ये सब एडवाइस करेंगे कि हम सीधे कह देंगे कि नहीं नहीं आपको तो एंजियोग्राफी कराना चाहिए, पता नहीं क्या प्रॉब्लम्स है? सो आप क्या कहना?
Madam, most important thing is we should see patient as a whole. Patient should be symptomatic. If patient is not symptomatic, we should not do anything. We can go ahead with basic management like ECG, 2D we can do, but unless and until patient is symptomatic, we should not opt for any invasive treatment modalities. For that matter, angiography also. Many patients come nowadays with routine CT coronary angiography reports, that this was done routinely as an office checkup, health checkup, and they'll end up with unnecessary interventions. See, if there is a borderline block, and if it is not interfering your day-to-day activities, we should not go for conventional catheter angiography routinely. So a typical protocol should be, if patient is asymptomatic and non-specific changes like ST flattening in inferior leads, or early repolarization syndrome symptoms, or say mild T inversion lead 3, or left ventricular hypertrophy changes in the ECG, these patients can be safely managed with medicines without angiography, even without CT coronary angiography. This has to be very clear, that if patient is not symptomatic, don't go for any invasive modality of treatment, unless and until it is indicated by very high degree. Suppose elder brother is died of heart attack at young age, and father is died of heart attack. In such patients, we should go for angiography.
Okay. और जैसे मेरे एक पेशेंट थे, वो जब भी थोड़ा बहुत चलते थे, चेस्ट पेन आता था, वो रुक जाते थे, तो दिस वाज अ टिपिकल एंजाइना। तो उनको जब हमने भेजा तो 2D को इज एब्सोल्युटली नॉर्मल, स्ट्रेस टेस्ट नॉर्मल, सारे कार्डियक मार्कर्स नॉर्मल थे। तो एडवाइज्ड की एंजियोग्राफी करो, पर वो मानने को रेडी नहीं है, क्योंकि वो कहते हैं मेरे तो सारे पैरामीटर्स नॉर्मल आ रहे हैं, ये तो हार्ट नहीं है, तो मैं एंजियोग्राफी क्यों करूं? ऐसे पेशेंट्स के लिए उनको हाउ टू कन्विंस?
Madam, this is very important. We should ask them what I typically say them that see if there is fish, if you take he is in pond, if you take a half water, he will survive. If you take another half water, he will survive. But the moment it grows to below critical level, it will just flicker. And this is the same thing happens with the heart. Heart is a muscle like a fish. He that needs oxygen supply. And what you have described is typical angina. And in the same category, we should ask for postprandial angina, which I forgot to mention. If patient says, we should ask proactively whether you get tightness in the chest after heavy meals. What happens after heavy meals is that coronary and cerebral blood supply is diverted to the mesenteric supply for digestion. And in such cases, if there is critical blockage in the coronary vessels, patient will typically get angina after meal, say 5 to 10 minutes later, and it persists for half an hour or 1 hour. This is very important, typical angina. And for your question that how to convince these patients, we should uh, talk to their relatives as well, because many times patients are headstrong, they just won't listen to us. And we should advise angiography on paper, immediate or urgent angiography, and we should document it, because I have got a couple of patients and later they repent that why we didn't listen, or rather they blame to us that we should enforce on us why we should go for angiography. There has been incidences with many cardiologists like this, and later on they blame to us. It's very difficult to convince a couple of patients, but we should talk to the relatives, and majority of times they will listen.
अच्छा, दूसरी बात ये है कि बहुत बार ऐसा होता है कि जैसे आपने किसी पेशेंट को सिम्टम्स थे, एंजियोग्राफी की, और आपको लग रहा है ब्लॉक्स हैं और साइमल्टेनियसली एंजियोप्लास्टिक करना चाहिए, परंतु पेशेंट एग्री नहीं करता, पेशेंट चाहता है मैं सेकंड ओपिनियन लूं, मैं ये करूं, मैं वो करूं। सो मतलब आपको ऐसा लगता है कि जब हमने साथ में एंजियोग्राफी की तभी अगर हम साइमल्टेनियसली एंजियोप्लास्टिक करेंगे, दैट इज मोर बेनिफिशियल to patient?
Right, madam, in such patients, it is always better let them take second opinion if patient are not ready. This is common customary with me that if patient is not ready, we should not try to convince more. Our job is to just to document there are blockages and give the proper options. If by any chance if something goes wrong while doing angioplasty, then they will blame us that we wanted second opinion. So this is typical scenario. This happens many times. But madam, by and large, these patients have got faith in treating a general practitioner or a treating physician, and they will agree if we talk to their physician or a general practitioner. 99% of the time they will agree. Very few patients say once in 3 months, 6 months, they will encounter such patients.
ओके, सो मतलब मोस्टली ये होता है कि जब आप एंजियोग्राफी कर रहे होते हैं साइमल्टेनियसली, अगर आप एंजियोप्लास्टी कर दें, दैट इज मोर बेनिफिशियल फाइनेंशियली, पेशेंट का जो स्टे है, या
Yes,
आपको सेकंड पंक्चर नहीं करना पड़ता या डाई नहीं देना पड़ता, एंड लेस चांसेस ऑफ कॉम्प्लिकेशंस.
yeah, absolutely. So
अच्छा, सो हमारे डॉक्टर्स ने पूछा है कि ओपीडी में मान लीजिए मेरे पास ईसीजी मशीन नहीं है, अब कोई पेशेंट आया, वो पैनिक अटैक है कि हार्ट अटैक है, हाउ टू डिफरेंशिएट?
madam, we have to see the heart rate, blood pressure, and we have to take the history properly. Patient typically says that I have got pain at this portion, and he will point out with one finger, or he will say this is pricking pain, or this is burning pain, and he will have pain at multiple sites. It will not be in commensurate to the a particular portion. It will be at multiple sites. and generally they have got some stresses, and typically, as I said, cardiac pain has to be more than 5 minutes. That has to be constricting, associated with sweating, and associated with back pain, and that should limit your lifestyle. So a typical pain is very common.
नहीं, पर अभी आप एक बात बताइए, सडनली आपको बहुत सारे, आपको, हम लोग तो एज ए जीपी हैं, पर सडनली ऐसा हुआ है कि बहुत ज्यादा पेशेंट्स 30 to 50 इयर्स की एज में, जैसे केके का हुआ, या मेरे एक पेशेंट था, सडनली पूरा टीथ वो किया, ऐसा लगा कि फिट आ रहा है, हॉस्पिटल ले गए, एंड विद इन 2 hours ही डाइड. तो जो यंग डेथ्स हैं सडनली हो रही हैं, ऐसे केसेस को हाउ टू प्रिवेंट या हाउ टू इंटरप्रेट, या क्या एवरी ईयर जितने भी लोग हैं सबका ईसीजी, 2D को, टीएमटी, ये कितना हेल्पफुल है?
Madam, ideally, each and every one of us after 40 years should go for annual checkup, routine ECG, 2D code, treadmill, and blood test. HSCRP, HbA1c, and lipid profile, these are must test. HSCRP fairly indicates what is the level of atherosclerosis in any vascular bed. For that matter, if it is coronary, cerebral, renal, or lower limbs. If HSCRP is raised, in such patients, even if your cholesterol levels are normal, we should put these patients on statins. This is very important. HSCRP is very strong indicator of ongoing atherosclerosis, and this patient should be put on statins. But for that, we have to rule out the infection. What happens though, if suppose patient have upper respiratory tract infection, URTI-like symptoms, and if we go for HSCRP in that scenario, it has to be high. So if patient is absolutely fine and on routine checkup HSCRP is high, we should go for HbA1c. HbA1c indicates your sugar control lower last 3 months. By chance, this happens. I got many patients after angioplasty 3-4 years, they are turning out to be diabetic. So routine HSCRP, HbA1c, lipid profile has to be done every year after 40 years.
ओके, सो एक बात बताइए डॉक्टर महेश, जैसे कि 5 साल हो गया आपने प्लास्टिक की थी, सडनली पेशेंट्स चेस्ट पेन, ब्रेथलेसनेस, सब कुछ लेकर आता है, सो क्या करना है, हम क्या एडवाइस करेंगे एज अ जनरल प्रैक्टिशनर?
मैडम, we should see whether this patient is failure. स्टेथो रख के पता चलता है if there are crepes, multiple crepes, rhonchi, it clearly indicates that patient is in failure. Immediate treatment is, if possible, give injectable Lasix if blood pressure is more than 100 millimeter of mercury. If it is bottle BP, or if it is permissible, if injectables are not available, we can give a tablet Lasix. Many times these patients will recover from a failure. And if it is acute chest pain, ideally this patient should be advised hospitalization. If it is not possible and BP is above 100, we can give sorbitate tablet and refer these patients. Sorbitate and Lasix, these two medicines are life-saving in such a situation.
ओके, बहुत बार ऐसा होता है कि यू आर सस्पेक्टिंग ब्लॉक्स, जब आप एंजियोग्राफी करते हैं, पेशेंट नॉर्मल, सब कुछ नॉर्मल है, छोटी छोटी जो कोलेटरल्स है वो ब्लॉक है, तो ऐसे केसेस में आप कैसा फॉलो अप करते हैं या पेशेंट्स को क्या एडवाइस करते हैं?
मैडम, these are called साइड ब्रांच डिसीज. सो उसमें क्या रहता है कि डायगोनल्स या ओएम्स, उसमें डिसीज रहता है, तो दिस patient should be treated in the same line as acute coronary syndrome, dual active platelets plus statins plus anti-anginals. But these patients do well only with medical management. If we try to interfere by doing angioplasty or bypass surgery in such patients, it will cause more harm. So medical management is best in such patients.
Okay. और this is not related with angiography, आज के टॉपिक से रिलेटेड नहीं है, जरा टाइप ऑफ स्टेंट
हो गया, ठीक है ना?
टाइप्स ऑफ स्टेंट,
यस
मैडम, see basically bare metal stents are out of fashion now. Practically we didn't get bare metal stents, so all stents are drug eluting stents. These drugs are different anti-proliferative drugs like sirolimus, tacrolimus, everolimus. These are anti-cancer drugs they basically prevent proliferation. So what we these are coated, these drugs are coated over some alloys like cobalt, chromium, and over this they are eluted over the period of 1 year. And typically what happens now, if you get a scratch, it takes almost 10 days to heal. The same thing happens with the heart vessels. If we try to put a stent and get this block removed, that endothelial lining, it takes almost 3 months to cover that stent. Once this endothelial lining has come up, there is no reason that that we don't need stent practically after that. And over the period of years, this drugs are eluted. We call it as drug eluting stent. And nowadays we have got absorbable stents. They have got different polysaccharides instead of cobalt, chromium, and these drugs are embedded in these polysaccharides, and over the period of 1 to 2 years, this stent material is absorbed. uh, these stents were in the market before 3 to 4 years. Again, one Indian company, Nerul, has brought this stents, and these should be typically placed in young patients with focal lesions. So I have put a couple of stents below 30 years, very small block at one point, so that these patients will benefit if require further intervention. So all above 40 patients, 40 years patients should get drug-eluting stents by and large. So
Okay. So how common is posterior wall ischemia, and क्या हमको ECG में पता चलता है, ECG में changes?
Yes, madam. Postural wall myocardial infarction is fairly common. Generally, what we see is ST depression in V1, V2, V3, and slight changes. Inferior wall myocardial infarction and posterior wall myocardial infarction, very subtle changes, very minimal changes on ECG, and we have to turn around the ECG, that ECG paper, and we can get typically acute interval MI. Suppose patient has got V1, V2, V3 ST depression. If we turn that paper and see, we'll see the changes of acute interval myocardial infarction. V1, V2, V3 will get ST elevation up. And this patient should be treated as ACS, ST elevation myocardial infarction. They have to receive loading dose, injectable, this low molecular weight heparin or conventional heparin. And this should be either thrombolized or referred to the primary angioplasty.
Okay, so I think Dr. Mahesh, एंजियोप्लास्टी से भी रिलेटेड बहुत सारे क्वेश्चंस डॉक्टर्स पूछ रहे हैं, पर मुझे लगता है दैट इज अ सेपरेट टॉपिक. हम लोग एक बार आपका फिर से एक और लेक्चर रखेंगे. So what is your take home message for us?
Madam, take home message is even for yourself, you should get tested for lipid profile and all other parameters related to heart routinely after 40 years every year, and this should be the norm for your near and dear ones. Secondly, don't hesitate to go for angiography if there is slightest degree of suspicion, because life is more important as compared to denial. Because if we go for angiography, nowadays angiography is very, very safe, almost nil mortality out of 10, more than 10,000 angiographies. And we should at least evaluate. Once we are done with angiography, then you can take a call whether to go for medical management or whether to go.
आपको ऐसा लगता है कि ये जो एनुअल चेकअप्स होते हैं उसमें कैल्शियम स्कोरिंग कंपलसरी करना चाहिए? क्या वो कैल्शियम स्कोरिंग एंजियोग्राफी से मतलब बेहतर है, या हम पब्लिक को ज्यादा अच्छी तरीके से कन्विंस कर सकते हैं कि पहले आप कैल्शियम स्कोरिंग कर लीजिए, अगर आपका कैल्शियम स्कोरिंग मोर देन 300 या 400 आता है तब आप एंजियोग्राफी करिए? तो आपको क्या लगता है जितने भी रूटीन मेडिकल चेकअप्स होते हैं जो हम एनुअल चेकअप्स कराते हैं, सबके लिए कैल्शियम स्कोरिंग कंपलसरी करना चाहिए?
मैडम, कंपलसरी करना चाहिए. ये दिस इज नॉट सीटी स्कैन, दिस इज जस्ट सीटी में यू हैव टू डू द फ्लोरोस्कोपी. जैसे एक्सरे निकालते, दिस इज सेम थिंग, कैल्शियम स्कोरिंग. They will just scan the patient and see the amount of calcification. It has to do nothing with coronary lumen. उसके अंदर ब्लॉक है नहीं है, that doesn't matter for them. If calcium score is high, we should go for conventional angiography. But this has to be routine. In my opinion, all of us should get this calcium scoring routinely.
Okay, so this is the last question कि जो एंजियोग्राफी उसकी कॉस्ट कितनी होती है?
Madam, it varies from hospital to hospital. catheter and all these things. Generally 12,000 to 25,000 is the norm in Navi Mumbai. Single room
Okay.
patients, they can go up to 75, 80,000 also. It all
Oh.
depends on class. Yes.
Okay. So मतलब same doctor, same procedure पर अगर आप deluxe room में है तो charges are high.
Yes, yes, yes. Very, very, very much high.
तो ढाबे की चाय and
5-star kitchen.
आज की चाय, yes, yes. So I think calcium scoring के charges तो 2,500 से 3,000, 2,500
Yes, madam.
to
Yeah, this is
3,000.
very
And
calcium.
every hospital is doing, I think हम सबको calcium scoring तो करानी ही चाहिए.
Yes, 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 yes.
So
And this is very common, madam. It takes less than a minute. वो CT scan के machine में जाना है and within a minute we'll get the calcium scoring report. If it is more than 400, we have to straight away go for catheter angiography. If it is less than 400, and if you are not symptomatic, you can wait and take a call if there are symptoms or risk factors like diabetes, hypertension, smoking, physical inactivity, bad diet habits, stress. In that case, you can individualize the further line of management.
okay. So thank you very much, Dr. Mahesh, for your valuable time and efforts.
Thank
Madam,
you.
can I ask one question?
Yes, please, you can
Yes,
ask.
madam.
Yeah. What about GERD patients with hiatus hernia? They feel discomfort and after food. How to differentiate?
Madam, I see these patients, GERD with hiatus hernia, it means these patients underwent upper GI endoscopy. If endoscopy has documented hiatus hernia,
Yes.
ideally this patient should be treated for hiatus hernia first. And if symptoms are recurrent, we can go ahead with angiography if required. It's very difficult to differentiate, madam, clinically. So there is no way out. We should keep these patients like that only. We should
Yeah,
treat both things.
their ECG and CT and all is normal. So we consider that.
Yeah, if CT, yeah, in such cases, see, if suppose patient is having GARD with hiatus hernia, and if he is non-hypertensive, non-diabetic, non-smoker, below 40 years, we can get CT coronary angiography for these patients. If it is normal, we should just forget. CT coronary angiography is just to rule out coronary blockages.
So
If there are
sorry, I
slightest
meant
suspicion,
2D. Sir, 2D I meant. Actually, I meant 2D. ECG 2D is enough to
no,
rule
it
out.
is not enough. It is not enough, madam. See,
Okay,
to rule out
okay.
coronary artery disease, ECG, 2D echo, and treadmill are not enough. See, United States, many of hospitals, they are now removing to treadmill machines, because if TMT is positive, it does not mean you have got heart disease. Or if TMT is negative, it does not mean you didn't have heart disease. If TMT is negative, you are falsely assuring patients that your heart is normal. And if your TMT is positive, you are making these patients panic by saying that this is abnormal. Even
Sir,
I
it's
have,
a good thing, sir. It's a good thing they have removed because it's very tedious test also.
madam, I am not doing TMT last 1 year. I have removed from my clinic.
Sir, when there are better investigations available.
Yeah, see, now CT angiogram, coronary angiography, this is matter of 5 or 10 minutes. TMT takes 15-20 minutes. So we should go for the best possible treatment modality.
It was very, very, very nice, very informative lecture. Thank you, sir. I'm attending from London.
Thank you, madam.
Yes,
Thank you very much.
Thank you, madam. Thank you very much.
It's my honor.
Yes. So
Can I
because
ask a question?
Yes,
Yes.
ma'am.
Can I ask a question, please?
Yes, madam.
Sir, if the calcium score is 400, not
Mhm.
less than 4 and not more than 4, then how do you interpret?
Madam, we should go for conventional catheter angiography. See, calcium scoring basically indicates calcium deposition in the coronary walls. It does not differentiate between intraluminal or extraluminal calcification in the vessels. So once calcification is there, we have to go for angiography. There is no doubt. We should rule it out. So as I said, this is important with respect to life. It's matter of life is more important in that. I mean, we should ask these patients to go for conventional angiography.
Thank you, sir.
Thank you.
So I think there are no more questions. So thank you very much, Dr. Mahesh. Thank you all the attending doctors, and thank you our team Navi Mumbai Doctors Foundation. So बहुत जल्दी मिलेंगे with the new topic angioplasty. So
Yes,
thank you
madam.
very much, Dr.